that time, it was winter time. This was a man from the Caribbean who had just come into Chicago to study dentistry. At the time, it was post-Civil War in the U.S. and Black people were not particularly prominent in the professions. So at the time he was admitted into hospital, the medical system had just started to deploy microscopes, and they admitted him for shortness of breath. This was a dental student. And as you can see, the house officer who was working in a predominantly white hospital at the time noted peculiar cells. You see and then that, so that although in Africa we've talked about sickle cell for a long time, the concepts of Ogbanje, Abiku, and all and the traditional recognition of recurring pain, it wasn't until this gentleman from the Caribbean that modern medicine, or at least written medicine, acknowledged a new disease, as it were, so that the doctors recognized this. Over the ensuing 2 years, Mr. Noel attended dental school in Chicago, and a few years after he presented, the doctors who took care of him, the consultant, Dr. Herrick, for some reason he omitted the name of his house officer who drew the picture that I showed you a few minutes ago, published this story of a patient with sickle cell, the first patient. They talked about unusual blood findings. This was a 20-year-old man, emerging adult. And in the paper, this original paper published in 1910, Dr. Herrick made a point at least 2 or 3 times to point out how intelligent this Negro gentleman was. He must have been a really smart man, because despite the struggles with sickle cell and the admissions for pain and pneumonias that he had, Mr. Noel actually graduated from dental school, moved back to Grenada to practice dentistry. Although there was no organized transition, he did manage to graduate. From that early beginning, you can see how sickle cell mortality has decreased over the years, how the life expectancy has improved, starting from the early 1900s, where the life expectancy was estimated to be less than 20 years, to today, where many sickle cell warriors are living healthy lives into their 50s and 60s. The result of this has been a result of strategic changes in the way sickle cell anemia is approached, starting from Richard Nixon signing the National Sickle Cell Act in 1971, the one that brought in routine newborn screening, the advent of penicillin, then of hydroxyurea, of safer blood transfusions, of better vaccines, have slowly but surely improved the lives of sickle cell disease warriors, of individuals who have sickle cell disease. I try to, in this slide, just point out the various sickle cell disease therapies that we have, but to then also point out that the sickle cell therapies have there are pros and cons, like in many things in life. And that if you think of it as on the left side, the perfect ideal treatment, and which of them have the cost, you go from hydroxyurea, which is fairly effective. You need to take it by mouth. Thankfully, the cost is coming down and has been proven over and over and over to be useful for minimizing some of the complications of sickle cell, to more recent ones. Some of my patients who take L-glutamine tell me that it tastes like salt, like chalk, so harder to get. So, but the data around it not quite as robust as hydroxyurea. To the another new one called voxelotor, which although it raises the hemoglobin, is not been proven to prevent pain. Quite expensive. So in a sense, I'm saying maybe not as effective as hydroxyurea, costs some money, and then to CREASE, the one we call CREASE, it reduces pain crisis in conjunction with hydroxyurea, but needs to be an injection every month, which is quite invasive and costly. To transfusions, to people who take transfusions every month, which although it reduces complications and pain, can be a burden to go to hospital to do a transfusion every month with all the iron overload that comes. And then on the top right side, I put the transplants and the ones that can cure sickle cell, including gene therapy. But to point out that although they are highly efficacious, they come with significant risk. So having said that, you would appreciate that in the data that I showed earlier of sickle cell disease in the 1970s had a very early in life, in childhood, there's a peak of mortality of a lot of children who died before they were 5 years old. And then if you went a little bit further, you see that in early teen years, there's the dotted lines I'm pointing to now, had slight increase in death, and now to be replaced with the condition, the situation we have today, where death in childhood is relatively uncommon, at least in high-income countries. I know that it's not exactly the same in this way in Nigeria yet, but we're all working towards that ideal. But also then point out that at the time when we reach that ideal in Nigeria, you see how starting from the young adult years, the mortality starts to rise again. And so that part of the discussion today is to say, well, how can we reduce the risk of early death, especially during that period where a young person who happens to have sickle cell is having to contend with growing up, have a chronic illness to deal with at the same time. And although it's exciting to gain independence, to get your own car, go up to university and to do those things, it can be daunting, especially in a setting of a chronic illness like sickle cell disease. So which then brings the concept of transition, which by transition I mean the purposeful planned movement of young adults and adolescents from care that tends to be centered around the child and the family to care that is now directly focused on the patient as an adult. Basically, we need to, in addition to just treating complications, children who are affected by sickle cell need to be trained in self-efficacy, trained in taking care of themselves, understanding their disease so that they can successfully navigate the adult-centered world. The kinds of barriers that we see tend to be that historically there are a lot of pediatricians who take care of individuals with sickle cell, fewer doctors who have interest or who are specialized in taking care of adults, poor coordination, and then as people grow older, there's end organ damage that develops, so that in early adulthood, many individuals affected by sickle cell experience stigma in the emergency rooms. People don't necessarily believe them when they complain of pain, and all of this then results in a lack of trust with the healthcare providers. The idea of transition is to say, look, if we know it is not easy to go from to grow up and do adult things, especially when you have a chronic illness like sickle cell to contend with. And then it's not just the chronic illness, it's the development of independence, the school, the emotional changes that happen, and all the complexities of growing up, such that affected individuals require time, specific guidance, and support to make the transition safely and successfully.
Communication.
The transition, there are several core principles of transition. I will say that transition there needs to be a planning phase, an actual transition phase where the child goes from the pediatrician to the internist, or even if it's the same doctor who takes care of them, but at least the focus or the approach to care will need to be modified as the person gets older. There's an Institute of Healthcare Transition that's partly funded by the US government, came up with these core elements of transition and the timeline that is recommended. So that in my hospital, for example, starting from the age of 13 or 14, part of the visit with the child is alone, without the patient, without the parents present. Everyone knows that we will treat them, so in terms of policy, that we will treat children and young adults until they're about 18 after graduating from high school, off to learn a trade or to go to college. We start to transition them. We will routinely role play with our young adolescents and patients, such that you come to clinic, I'll say, look, what would you do if you had a fever? Or what would you do if your mom or dad not at home? Do you call the clinic to make your own appointment? What about what medicines do you take? Can you list them for me? So these are ways of gradually getting the young person to take charge of their care. And over time, when we finally transition them, we have relationships with the internal medicine adult physicians who take them. And then about 3 to 6 months after the child has moved on to the young adult has moved on to the new physician, we still keep in touch by phone for about 6 months to a year after that to make sure that they integrate into the new practice and that they're fine. The Institute of Transition that I mentioned earlier, I'll leave you the web page to it, has forms that parents and doctors can use to monitor the transition. This is a screenshot of one that is directed to parents of children starting at the 12, 13, 14-year-old time frame that lists readiness activities that a person should be able to complete. And so that with a form like this, you tick off all the ones that the child has accomplished, and then work on the ones that they haven't. And some of it requires special training. So in summary, I would like to say that I talked about hydroxyurea. It's feasible, it's effective sickle cell modifying therapy. We know that transplant is a cure. There's gene therapy, allo transplants coming up will be the cure, but so far they tend to be expensive, they're risky, and not so accessible. But specifically as it relates to transition and navigating care to the adult setting, every sickle cell patient should know what kind of sickle cell they have. Is it SS? Is it SC? What kinds of complications they've had? They should know you should know for yourself, or at least as a as an advocate, working with sickle cell warriors, know what your treatment plan is. What kind of pain medicine works best for you? What kind of other non-medicine treatments will work, so that you can speak up when you visit the doctor, or unfortunately there's illness. You should know who your doctor is. The information should be readily available. If you are one of those who have insurance or means to pay, you should know all the numbers and the registration, so that you know exactly which hospital to go to. And lastly, a person with sickle cell is first and foremost the warriors are people who happen to be dealing with a chronic illness. So that apart from sickle cell, each person has complexities and challenges in their life. So what about the other components of your fabulous life? What is it that you want to do to make a living? What is it that gives you joy? So as part of our transition planning for our patients, we have social workers, and actually the clinic also, we have a counselor that also talks to the kids, assesses them, and does life counseling for them. Does everybody want to go to university to study engineering? What about if that's not within capacity or interest? What about some other career planning? All of that needs to be part of the navigation from pediatrics to adult living, such that we not only just focus on a disease, but also look at the whole person. And of course, I'll be preaching to the choir if I but what I'm saying is that if you have sickle cell, be an advocate. The rest of the world needs to know that sickle cell is not a curse. It is not a death sentence. It's not from witchcraft. It is not incurable, and it's not even rare, and it's not just for Black people. So that at least that is a way to occupy yourself, advocate, and change the world. I put here the Form a Bridge group is very active in with transition guidance. And if you permit me, I have maybe 2 minutes to show a video of sickle cell warriors who have of a sickle cell warrior who's been a major inspiration to me. And this will only be 2 minutes. It's a YouTube video, and this is about a colleague of mine who. One second, I just need to do a new share.
My name is Titilope Fashipe, and I'm the co-director of the.
Do you see the video, by the way?
Yes, we can see the video, sir.
And can you hear it?
Yes, we can hear.
My name is Titilope Fashipe, and I'm the co-director of the Sickle Cell and Thalassemia Program at Texas Children's Cancer and Hematology Centers. I'm also an individual living with sickle cell disease who grew up and became a doctor. It is very important that teenagers see others survive sickle cell disease, other adults, because it matters when you meet your first 30-year-old person with a job and a car. It's exciting. When you meet a 50-year-old woman that has children, it's exciting. You want to know that your life can be like theirs. I think it's very important for you to think about yourself as an adult. It's hard sometimes, but I want you to think about your future and dream about it. You might want to become a doctor. You might want to become a lawyer. I already see you doing those things. So I want to make sure I keep you as healthy as possible when you're this younger age so that you can do those things and do them well. Appreciating your adult future allows you to stay healthy enough to actually reach it and achieve it. We all hate pain crises, but we know that they're a reality when you have sickle cell disease. So the tips I can give others when they're going off to college or when you're not with a support team that you usually have from home is to have a care kit. So what I learned quickly was that if I had a little care kit under my bed, I didn't need to worry if I had a pain crisis in the middle of the night. So the most important things to have in a care kit are your favorite drink, the medicines that you know work for your pain, and you also want your heating pad or heating blanket. Whatever it is, have the things that make you feel comfortable when you're in pain. And then have a great go-to list, a need-to-know list of friends or a friend that you trust that can help you whenever you do have a pain crisis. Sickle cell is a very tricky disease. It's kind of unfair and mean. Every time you have a pain crisis, it's a reminder that something's wrong. The advice I have for maintaining a positive state of mind is to definitely be you. You're unique, you're awesome, you're cool, just the way you are. And I know your parents probably tell you so and you roll your eyes, but it's true. I think it's important to embrace that there's only one you, and you gotta do it the best that you can.
Okay, so thank you very much. So thanks for the giving me opportunity to speak with you.
Awesome. Thank you very much, Dr. Gladstone. Awesome. What a time there. What a time. Meanwhile, Dr. Titilayo Fachkweda, you showed us that video earlier. She joined us on the program about 2 years ago. So she's a known face to the Sami community. Thank you very much for the wonderful session we had there. Is that a person with sickle cell? First and foremost, you are a person. What are the other components of your fabulous life, your dreams, your goals, your aspirations? You should put that in mind. And said, know for yourself. What kind of genotype do you have? What are your treatment plans? What medicines work for you? What kind of non-medicines work for you? And then he talked about hydroxyurea being a very feasible and effective SCD modifying therapy. And also transplant, although being efficacious, also comes with significant risks. So before you go, sir, we would have about 10-minute question and answers so that people who would like to ask you questions on what you have shared and also probably other things as it pertains to sickle cell, you can have them now. So audience, you have questions for Dr. Gladstone. About 10 minutes opportunity for us to ask him questions. You can drop on the chat, and if you'd like to speak, you can also unmute and speak. Questions from anybody on how to manage sickle cell?
We have a lot of people
I'm going to the
saying
comment
what
section.
are the enlightening social. Yes, read. You can go ahead.
What an inspirational video. That was enlightening from Dr. Oge. What an inspirational video. That was enlightening from what is this person? Thanks for joining, Peter. Dr. Grace Ochibo says, awesome, such an enlightening session.
Okay, let me ask Dr. Gladstone this question because I know the challenges between developing countries and non-developing countries can be quite wide apart. But okay, there's a question here. before I now go to my question.
Yes, see a question from Olusegun Adeshokon. In your opinion, Dr. Glassman, I hope you can hear me. So in your opinion, is transitioning from pediatric to adult care different from, I think, different from between Nigeria and US, I think? Can't see if I get that.
Yeah, it says, in your opinion, is transitioning from pediatric to adult care different in Africa, in brackets, Nigeria, versus what it is in North America? I recall growing up and I had to attend same sickle cell clinics with adults.
Oh, okay.
Yeah, I mean, can you hear me?
Yes, we can.
Yes, we can.
I can tell you that traveling, I've had the opportunity in the last say 10 years to travel different countries in Africa. For example, when I traveled in Angola, they did not have adult sickle cell clinic. They, in the big general hospital, they have pediatric clinics that were busy, heavy, and none for adults, at least in the public health system. And it was the same in some parts of East Africa too. And part of that, as I understood it, related to the idea that, oh, you diagnose children and people just either lose hope, or there was very few organized sickle cell adult programs. But in a sense, even if I think that the needs of a child are significantly different, such that if it seems like 2-year-olds are attending the same clinics with 30-year-olds, I will imagine that is a result of a lack of resources, as it were, because their needs are different. It could be, as I mentioned earlier, you could transition. There are family doctors who, for example, who treat children and adults, but these family doctors are trained to modify their approach when they encounter children versus when they talk to adults. So there are differences, but I mean, there are differences, but the underlying issue that a person moving from pediatric centered care to adult centered care requires some planning and deliberation still holds true. Although I can imagine maybe some private general hospitals where it's the same doctor treating everyone, the difference may be blurred a little bit.
Yeah.
All right.
There's another question. Oh, Dr. Oge has a hand up. Then we'll take the next question from Dr. Bunkoya. Dr. Oge, go ahead.
All right. Good evening. Can you hear me?
Yes, please.
Yeah.
All right. Thank you very much for that insightful presentation, Dr. Gladstone. I just wanted to ask, are there any particular concerns for sickle cell carriers? So the AS people who have AS or who are AS. In more recent times, I had engaged in a discussion with a hematologist who said that actually, if you're AS, you should see a hematologist to be able to assess levels, and because under certain conditions that people who are AS could actually have crisis and other complications. So I just wanted to know if you might be able to shed any light on that. Thank you.
Yeah, I mean, I think that sickle cell disease is autosomal recessive. Patients or individuals who carry the trait are not affected. In the US literature, there are case reports of people who have the trait, who, for example, and I'm talking fewer than 50 so far recorded, who had fatal events playing American football, you know, with the big pads and stuff. It is not entirely clear to me that that is a problem with sickle cell trait rather than football itself. I say that because every time someone says, oh, if you have sickle cell trait, there's risk for playing football. I say, well, but there are a lot of people with sickle cell trait in Africa and Brazil who play the other kind of football, soccer, and nothing like that is happening. So it's very controversial. I'll say for sure, though, that individuals with sickle trait do not see hematologists. An individual with sickle trait does not develop pain events, do not have pain events. If a person with sickle trait has pain events, the diagnosis should be reconsidered because it doesn't cause pain events. What I know has been reported for people with sickle trait is the occasional rare patient who might have hematuria, a small increased risk of pulmonary embolism. But I will say though, like looking from the viewpoint, I can imagine an American or European hematologist saying, oh, it's some disease, but just based on my whole general idea, I would say that if I was practicing in rural Nigeria, in Elisha or in some place, and I was doing a newborn screen, and I walked in, the one with sickle trait, I'll rush in the room and high-five the mom. Because if you look at the data out of Africa, kids who have sickle trait are less likely to die. I mean, I've seen data from Kenya where they looked at kids over 5 years and drew survival curves. These were kids, some with sickle trait, some with normal. The ones who had normal AA were less likely to live to 5 years than the ones who had sickle trait. So that if you put all that together, I would say that sickle trait is not a disease. Sickle trait does not need to see a hematologist. And the occasional reports of people with sickle trait who have issues with sports. But then the sports authorities here in America say, oh, if you have sickle trait, make sure you drink plenty of water when you are exercising. Make sure you don't go play hard sports if you feel sick. If you have asthma, make sure it's well controlled. But I say that should be advised for everyone. If you don't have sickle trait, do not play if you have asthma unless it's well controlled. If you do not have sickle trait, if you are feeling shortness of breath, do not keep playing. So that I do not personally believe that sickle trait is a cause for concern. And I believe that a person with sickle trait in rural Nigeria or Uganda, where malaria is endemic, tends to do better than the one who's AA.
Yeah. Thank you very much, Dr.
Thank
Gladstone.
you. Thank you.
Thank you very much, sir.
The final question. Yeah.
Ramola Ogunkoya. Thank you, doctor, for your presentation. What are the emerging therapies that are promising for the future? Also, how can already available therapies become more affordable in low, middle-income countries?
Yeah, I mean, personally, I think that we have, okay, right now there's hydroxyurea. 10, 15 years ago, hydroxyurea wasn't even as well sourced in Nigeria compared to the others. I think that this kind of advocacy that SAMI does basically to push governments and also the big international pharmaceutical companies that make some of the new therapies, right? For example, Voxelotor, the Endari medicine, one of the ones I mentioned, as I recall, Pfizer recently purchased owns the pharmaceutical company that's doing it. Similar to what happened with HIV. I don't know if you remember the history of HIV. There was HIV, antiretrovirals came, and the price for these medicines were so high that it was only available to people in Europe and in some of the high-income countries. The advocacy was such that it forced the manufacturers. If you look at the history with the Bill Gates Foundation and the global HIV action networks and stuff, was so intense all the way to the United Nations that it forced an availability of expensive antiretrovirals to people around the world. So that I would say it will be a combination of advocacy to local governments, to big pharmaceutical companies at the level of the United Nations to say that this is an important issue that has significance for everyone in the world. Other than that, I can't think of, because right now the medicines available, some of the medicines are available, but they cost too much. They cost so much because the pharmaceutical company wants to imagine recoup its investments in it. So I'll say that it's advocacy that will do it, and the advocacy needs to start locally.
All right, sir. Thank you very much, sir. I think with that, there are no other questions, so we can say thank you very much for this opportunity of sharing with us. It's actually very great. We thank you very much for this opportunity. Thank you very much, Dr. Gladstone. I believe that you've done justice to. Okay, Dr. Grace Uchibo says my hand is raised. Sir, can we take that question before you go, sir? From Dr. Grace. Dr. Grace, over to you.
Thank you very much, sir. Thank you for the presentation, sir. So part of the things that is our major issue also in Nigeria, sir, is the academic pace for children living with sickle cell. And because of the frequency of crises, they are always out of school, and then they have this delay in their academic program. So way before the transition, and even during the transition program from pediatric age to the adult healthcare delivery, is there any program, where you probably work with the school system to ensure that all of this are put into like proper perspective, sir?
Well, I mean, yes, but not limited to sickle cell. Kids with sickle cell, either because of stroke, frequent pain events, or lack of attentional problems, hyperactivity, could fall behind in school. Although a greater number of children with sickle cell have this complication, these are also complications that can happen in children who have diabetes or who don't have any chronic illness at all. Public school systems, at least in the US, have to be that are government funded, have to adhere to the ADA disabilities law, so that any child, our hospital, for example, has neuropsychologists, and every school system also has them, to test children who are falling behind and to offer accommodations to them, either by extra lessons and all that. So there are facilities for children with sickle cell, but they're not just fashioned for kids with sickle cell. These are public school accommodations that are offered to all children who either have a chronic illness or have a learning disability. And that's an important area to go, because I've met children I met a child in Dar es Salaam earlier this year who had a stroke. And when I asked her how she'd recovered really well from her stroke, I asked her how she's doing in school, and she said, "Oh, I'm not doing so well." I say, "How can we improve it?" He said, I've asked the teacher to not wipe the board before I've had a chance to copy it,
Copy.
That is something that would have been so a little bit easier to fix, is to tell the teacher, perhaps you should write things on the board, but not expect this particular child to have to copy all the notes. What about we've arranged for you to take a photocopy of the notes written by another student and then to give to a teenager to go home to study. So that's an example. So I'm glad you brought this up. It's something that we need to pay attention to, such that the education of every child is individualized and not have the child go through school. I write it on the board. I expect you to copy it really quickly. So if I have a physical slowness or deficiency, I'm not able to copy, therefore I've lost my chance to learn. So that's just an example. Thank you for bringing that up.
Thank you, sir.
Okay, so
Awesome.
thanks for the opportunity. I'll have to run now. To go
Yes, sir.
on
Thank you very much, sir.
patients. Thank you. Bye.
Thank you so much.
Patience to
Say
Sammy.
thank you, Dr. Gladstone, on the comment section.
Thank you, Dr. Gladson. Please share your screen.
Okay. Oh, I need to unshare it.
Yes.
Yes. Okay, I have done so.
All right.
Thank you. Okay. Bye.
All right, man. I think we can move
Yes,
on.
go ahead. Yes, please.
Okay, so I think we can move on to the second guest, the second speaker of the day, Dr. Oge. Do we have a bio ready, man? Can you play now?
Yes, just a second.
Okay.
Sorry, wrong person. Dr. Oge. Can you hear the screen? Can you hear me?
Yes, we can hear you.
Yes,
Okay.
we can.
Okay. Right. So I wanted to be sure that the thing was playing. Dr. Oge.
That's your bedroom.
I think it's playing behind, but we can't hear generally.
More recently completed. Thank you. Ahead. Okay. You can come up now. Thank you. So, okay, can you hear me?
I can hear you now.
Yeah, okay. I was saying you can come up now.
Oh, okay. I thought you wanted to play the bio, so I wasn't
Yes,
sure
we
if
played it. Okay, you
okay.
didn't hear it.
No, I didn't hear it. I don't know if other
Or
people
did
did,
anybody else hear
but
it?
that's fine.
I didn't hear from my end, but I know
Because that's why I was
it was
asking.
playing. I noticed it was playing behind, but it's
Oh dear,
not
I'm so
good for
sorry.
everybody.
I'm so sorry. Yeah. Should we do it again? We should just go on.
Let's go on. Let's go on.
Okay.
Okay, I'm just trying to share my screen. Hopefully you can see it.
You can see your screen already, man.
Okay, fantastic. So thank you very much to all the members of Sami Maureen, everyone who's invited us, Lakeshore Cancer Center, to be part of this event today and tomorrow. My name is Dr. Oge Ilebune, and it's all right about the bio. I'm a family physician or general practitioner, and I'm also the head of strategy development and outreach at Lakeshore Cancer Center, Victoria Island. Lakeshore also has a center at Ikeja GRA. So we actually have two facilities within Lagos and a third one coming up soon, which is going to be the radiotherapy center. Hopefully by the end of the year, we should start that. So the other things that we do at Lakeshore, apart from treatment, is cancer education and screening. And that is exactly what I'm here to do today. That's part of my own mandate, advocacy, discussing, putting ourselves out there. If there are things that people need to clarify, questions, being involved. What we don't really want to do solely is just to wait for people to develop cancer and come to the clinic. We want people to know preventive measures. We want people to know screening measures so that even if there's something, it's caught early at a time when people can actually do something about it, the doctors, the nurses. It's a whole medley of multidisciplinary members of a team. So when we talk about cancer care, it's not just, oh, the doctor. We have so many specialists that are involved. And so I think I'll just go on. So this is mainly cancer screening guidelines. It's just to talk us through what we all should be doing. It's not just people out there, but all of us as individuals, male and female. So the first thing I would like to do is define what is cancer. I'm aware that there are other speakers. So normally I'm a bit interactive. I ask questions while I'm speaking so that it's not just a lecture and it's engaging, but I'm also mindful of time. But please feel free to stop me at any time if you think I'm going too slowly or too fast, or if you have any question. So we know cancer as the growth of abnormal cells, okay? The human body is made up of cells, as we all know. And the cells actually mimic what we know in reality. Babies are born, they become, toddlers, they become, children, then they become teenagers, young adults, and so on and so forth until, we get to a point when we're old and then we die. So that is the normal cycle of life. But with cancer, what you find is that these cells, instead of, being born in quotes and then dying off, giving rise and room for new cells, they just continue to proliferate. And in some cases, they proliferate and grow so much that you can actually feel them as a tumor. That's what we call a lump. When people say, oh, I felt a lump in my breast, it's that proliferation of cells that have refused to obey the usual rule of nature. And the other thing about the cancer cells is if they just stayed there, so if it was a breast cancer lump that you felt or something in the thyroid and it just stayed there, then the doctors, especially the surgeons, will just go there fish it out and take it away. But the thing about the cancer cells is that they have the ability to invade and damage normal tissue. What does that mean? They leave that area and begin to, just imagine something trying to get out of where it is. So in the process of doing that, they are tearing down, they are damaging whatever is in their path, whether it's blood vessels, whether it's other tissues. And the whole objective is that they want to spread to other parts of the body. And that's when you hear the word metastasis. People say, oh, it was a metastasis. It just means that the cancer left the local area and went somewhere else. That could be the lungs, that could be the vertebra, that could be the liver, that could be the brain. And so that is the one part of the cancer, continuum that is very, very sad. So in Nigeria, so we'll bring it down to home, we have the four, what we call the big four cancers, the cancers that we know are, living with us here. But interestingly, these four cancers are also the cancers that you can screen for. So that's where it gets interesting. You can actually screen for them, and you can do all sorts of things to also prevent them. So these cancers are, this is the point where I would have asked, could someone tell me what the big four cancers are? But let's forge on. So we have the breast cancer, we have the cervical cancer, we have the prostate cancer, and we have the colorectal cancer, also known as the bowel cancer. So the breast affects the woman, cervical affects the woman, prostate affects the man, and colorectal affects both men and women. Once in a while, I throw the question and I ask the men, could you tell me where the cervix is? Does anyone know what the cervix is? And I've had very interesting responses. And likewise, I do the same for the women. I said, can someone describe where the prostate is? Do you know what the prostate is? And I have had very interesting responses there. I wouldn't ask tonight, just know that the cervix is the mouth of the womb. So when you have the womb or the uterus, if we use a medical term, it's that mouth of the womb that eventually expands when a woman is having a baby, it becomes very wide. So this area is very prone to cancer cells. And for the men, the prostate is what we call a walnut size, looks like a nut at the base of the bladder. That's exactly where it is. So some people have thought, oh, it's the scrotum, the testicle, but no, that's totally different. So the prostate gland is situated there, which is why sometimes when men get older and the prostate enlarges naturally, physiologically, nothing wrong, no cancer, they begin to have symptoms, urinary symptoms, because this prostate is kind of constricting the neck of the bladder, so the urine doesn't flow as easily. And then colorectal, we know, is the whole bowel, the large bowel. And then the breast, I think, is the easiest one for most people to know. And breast cancer is also one of the, in terms of numbers, the incidence, really, really high in sub-Saharan Africa. And so this is something that I wanted to touch on, cancer staging, very briefly. In terms of, we have patients who come to us after they've been to other places. And it's very sad that treatment has just been started arbitrarily without the staging actually being done. The staging tells you, right, at what is the status of this cancer in relation to this person at this point. And the staging is what determines what treatment is given to a patient. So someone who has stage 1 cancer does not actually have the same treatment modalities as someone who has stage 3. And even within stage 3, you have stage 3A, B, and C. So it's, it's not complex, but it is there's a lot more than saying, oh, this woman has a breast lump and I'm just going to take them to surgery and take the lump out. No, you want to know certain things about that lump. If it's cancerous, what type of cancer is it? And what stage is it? And all sorts of what are the receptor status? So these are things that we try to educate even the doctors who are out there that see patients as first line. Once you know it's a cancer, redirect them to centers that actually handle this. So stage 0 just means there's no cancer. The cells are not cancerous, but they are already abnormal with the potential to become cancerous. Then stage 1 is early stage. There is a cancer, but it's very small. It's very localized, very, very localized. Then stage 2 and 3 overlap. The main thing is that the cancer has got bigger and it's left the area where it is and it's beginning to grow out. And then stage 4 is the cancer has gone to other parts of the body. We are very much interested when we talk about cancer prevention and screening. We're very interested in the stage 0 and stage 1, because the earlier you find something, the quicker and the most effective the treatment will be. In other words, someone who has a stage 0, stage 9 really has almost 99% chance of continuing with a normal life. The cancer is there, it's taken out, the treatment is done. That is not to say that as the cancer progresses, stage 2, 3, even 4, that people still cannot, modern medicine means that we now have so many treatment modalities. But you can imagine it gets a bit more complex. It also gets a bit longer. And importantly, it gets more expensive, especially in our part of the world where we don't have healthcare financing for people. You're either paying out of pocket or you pay insurance and you're battling with your insurer to know what amount of money they can actually give you. So the earlier, the cheaper, the emotional burden, and that is why we promote screening a lot in our facility. So what does screening actually mean? Screening means that you are doing tests and examination in people who actually don't have a problem. There's no illness. Nobody is complaining of anything. You don't have a lump. Just every year, just like you do your blood pressure, your blood sugar, your cholesterol and all that, you screen. Those are screening. You don't have any disease whatsoever. But, you do that because you've now come to a certain age when you should be doing X, Y, Z. This is different from a diagnostic. Diagnostic means that there is something there already. You have noticed something, or your doctor has noticed something, and there is concern, and they send you for tests and examination. So these are two different. Screening tests and examinations are different from diagnostic tests and examination. And of course, again, just like I've said, the goal of screening is you want to find this early. You want to find it when it's small and there's a cure for it. So let's talk about the breast cancer screening guidelines. Like I always say to my daughter, who's a young adult, once you have breasts, you can actually see breasts, you need to examine your breast yourself. And so if you have a daughter, a niece, a granddaughter, whoever, someone, within your care who already has breasts, it doesn't matter if they are 14 or 18, they need to learn how to feel their breasts, get to know their breasts, so that if there's something different, they pick it up. I use the illustration that for women, when you have a pimple, when you have hair, when something's going on. That's because we spend a lot of time looking in the mirror. So you get used to your face. And it's the same thing that should happen with the breast. So even though this says start from age 16 to 18, to be honest, young girls are actually a lot more mature these days. And if they do have breasts, then you need to teach them what to do. So again, you want to be familiar with how your breasts look. And this is done monthly, usually after your period. The reason you do it after your period is that at least 5 to 7 days after your period is that most women tend to have hormonal changes occurring every month with the breast. So your breast gets a bit sore, some get a bit, bigger. So when you examine either during your period or just before your period, it's not as objective. You might feel pain, but you're not sure Is this pain because of the period? So it's better to wait until you've had your periods, give it about 5 or 7 days, then you examine. The American College of Radiology now suggests that women should have a mammogram at the age of 40. So what we say is, until you get to your mid-30s, you know, you do your self-breast examination. Then from your mid-30s onwards, you go in every year, see a doctor or a nurse who examines the breast. Note, I said who examines the breast. It's not every clinician who is involved in breast cancer screening. So be sure you pick out someone, whether it's a doctor or a nurse, who does this routinely and is used to it. And then by the time you get to age 40, so as you know, we are celebrating that landmark birthday, 40, you remember that that's the year your mammogram starts. Different countries have different start ages, but the American Cancer Society also seems to be ahead. So most places are now doing the mammogram at 40. I think the UK, United Kingdom still does it at 50. And many people there are complaining that that's a bit too late now. In Nigeria, we do it at 40. At least Lakeshore does it at 40. And then it says that when you get to 55 and older, you can switch to having it every 2 years. I will also clarify here that these sort of changes, if you have a family history, genetic predisposition to breast cancer, that means you don't wait till 40, you can actually start having your mammogram earlier. So if you have your GP, you have a discussion, you give them all your family history, all your medical history, your GP then knows your history and will make sure that you get all these things done at the right time, which is why I always say adults, starting from young adults, should actually register with a family practice, with a doctor who becomes, their co-partner in their health journey. Okay, this seems to have, okay, sorry. Okay, clinical breast examination. So I've gone through this already. The only thing to mention here is that if you're already in the menopause, meaning that you can't time your breast examination around your period, just select a date every month that you check your breasts. That's it. So this is your breast self-examination. What you tend to do, in addition to feeling the breast itself, you actually have to check the armpits as well. So, it's it's not expensive at all. It's totally free. All you need to do is just find some privacy and do this. And even though, excuse me, it says monthly, to be honest, you can examine it, your breast as often as you want.
Bless you, ma'am.
Thank you. Sorry. I have a bit of a cold.
It's fine.
And again, like it's suggested here, you can keep a journal if you want of your findings as well. So this just says, when you check your breast, what should you be looking out for? People tend to hinge on the lump. When people talk about breast cancer, the first thing is a lump. Actually, there are different things. There are different things that can indicate there's something wrong with the breast, and it's not just the lump. It can be a change in the size and the shape. It can be a rash or redness that doesn't go away for weeks. It can be a sore that is not healing. It can be a discharge from the nipple. Meanwhile, there's no lump. You can just feel a discharge from the nipple. I know someone whose first indication that there was something wrong was a stained shirt, blood from the nipple, and she had never felt a lump. Then it can be a swelling, not on the breast, but under the armpits, in the armpits or around your collarbone. And then, of course, there's a lump or the thickening, which is the one we're all familiar with. It could be a change in the texture of the breast itself. In some cases, it looks like an orange peel surface. Then it could be that the nipple becomes inverted. So let me stop there and explain. most people have everted nipple, meaning that the nipples stand out, pointed. But there are people who are actually born normally with inverted nipples. So that's not what I'm referring to. I'm referring to someone who normally has an everted nipple, and then suddenly when they examine this month, they notice that one of the nipples has gone inverted. That is a red flag. That is a warning. And then pain. To be honest, most people with breast lumps, especially cancerous lumps, don't normally have pain as the first thing they notice. But if you have pain, constant pain in your breast or your armpit, you need to have it checked out. It's important to note that breast pain does not indicate that you have a cancer. There are all sorts of reasons for breast pain. It could even be the period. It could be poorly fitting bras, which is why women should ideally measure for their bras at least twice a year. And so this is, again, the examination. What you tend to do, you first look at the breast in front of the mirror because it shows you the whole expanse of the breast. You clasp your hands and then press your hands forward, put your hands on the hips, blow slightly, and all the time you are looking at the mirror. Then you use the flat of the opposite hand and check the opposite breast. And when you do that in a circular manner, clockwise or anti-clockwise. You press the nipples as well, checking for any discharge. You check the armpit, and then you do the same while you lie down. Okay? This is what happens when the doctor or the nurse also examines you, which is called the clinical breast examination. Now, mammogram, there's been a lot of, myths around the mammogram. Oh, it's very painful. You can get cancer from it. So I'll explain. It's not the most comfortable examination because, the breasts have to be, the radiographer who carries this out has to get the whole expanse of the breast and the armpit. But it's bearable, very bearable. And it's also very low dose X-ray. So I want to repeat that, very low dose, almost the same, if not lower than the radiation you actually have when you're outside. So it's very low dose and it's an X-ray as well. And it's not done regularly, every 1 to 2 years. So again, having regular mammograms can, lower the risk if something is found early enough. From age 40. Right, so for cervical cancer, which is the other cancer for women, one of the things that is very, very important to note here is that 99% of patients with cervical cancer actually have as the cause, the causative element, as the HPV virus, the human papilloma virus. And the human papilloma virus is a virus that actually most people who are sexually active would have been exposed to. So it's not actually a sexually transmitted, it's not because of promiscuity or anything like that. It's a virus like most viruses, just that it can be exchanged between partners. But the interesting thing is that most people who have been exposed to the HPV virus actually clear it. So it's like me now, I've come down with the virus. I have a cold and I can feel the beginning of a cough. But if my immune system is intact, within the next few days, I should, clearly I'll still take some paracetamol, take some vitamin C, but the immune system is also working alongside anything I'm doing. And within a few days, I don't know that I had a cough or cold or sore throat. It's the same thing with the HPV. Once you have an immune system that is active, working, it clears the HPV. You don't notice it, especially with the location of the cervix. You don't even have any symptoms. You don't know that you ever had HPV. But what then happens is, in some people, for whatever reason, either the immune system is low or they've been exposed to something else that reduces the immune system, they then have a persistent HPV. And this persistence of the virus means that the virus begins to cause changes in the lining or mucosa of the cervix. So initially, if you are screening regularly, you could actually pick up HPV or pick up, when you do your pap smear, some abnormality in the cervix. And that is where the screening comes in, picking up things early. And at that point, something can be done. The gynecologist has a look, they carry out a couple of procedures, and this is even what we call pre-malignant. There's no cancer cell. But then if you leave the HPV, you're not doing your checks, nobody knows what's going on there. The HPV continues to cause changes, and you then go from the precancerous to the outright cancerous state. And by the time the person knows and starts having symptoms, that is where, you know, the problem is. You're now either stage 3 or, you know, stage 4. So the whole idea of cancer screening is to know that it actually takes about 3 to 7 years from the time the changes begin to when it's an outright cancer. So that's a long time. You can actually fit in at least 2 cancer screening pap smear within that 3 to 7 years. That is the importance of screening. And so what do we do? Traditionally is a pap smear, or we call it the liquid-based cytology. You introduce a brush through the cervix and you collect the sample and it's sent off to the lab. Now, the studies are showing that it's also a good idea to do the HPV test, collecting the sample so that the lab can tell whether there's a presence of HPV and what type of HPV, because there are over 100 subtypes of the HPV. And this can all be done in Nigeria. We do this all the time at Lakeshore, and there are other facilities that do that. Nobody needs to go anywhere outside the country for this. It's, you know, very straightforward, actually. And so how often should these screening be done? We usually say every 3 years if you're doing the LBC and the HPV testing. But once you start doing the HPV testing, what we call the co-testing, from the age of 30 to 65, you can actually get away with every 5 years. But if you're doing the LBC or the pap smear alone, it's every 3 years. The age to start is from 21, you know, within this age range, 21. But actually, again, in the times that we're living, our kids are also becoming more exposed earlier. And so the studies actually have suggested that once you become sexually active, you should start having your cervical screening 3 years later. And so that means effectively, if you have a 13-year-old who is having sex, they should actually start checking for HPV and cervical screening from about 16, 17. So this is something to bear in mind. So this is what it looks like. You introduce the speculum into the cervix through the vagina, then you use that brush, go to the mouth, the os, what we call the cervical os, and, you know, clockwise, collect the sample, then take it out and put it in a container, which we send off to the lab. I'll just mention that as a preventive measure for cervical cancer, we're huge on the HPV vaccine. So this is something that actually has a vaccine. And I don't know if anyone is aware, Nigeria for the first time is going to roll out the national human papilloma virus vaccination from September this year. So this is something that is normal already in the West. You know, you get your vaccine done, but Nigeria, you know, our health system as it is, but finally, this is happening. Some of us in the private sector, some of the facilities have actually been doing HPV vaccination already. We've gone from the Severix, which only covers 2 subtypes, and we have progressed to the Gardasil, which is another type of vaccine, which covers either 4 or 9. So this is progress. And the whole idea for the prevention is that, you know, just like the children's immunization, once you give it, the body develops antibodies so that when it's exposed to HPV, it can fight it. And so the idea is that you should actually give it, if possible, to those who are not sexually active. So that's school-aged children, but progressively with the Gardasil, you can actually take the vaccine right up to the age of 45. So this is something that is going to start happening. Nigeria is going to be using the Gardasil 4. The Gardasil 9 is exceedingly expensive, but the Gardasil 4 is high up from the Severix, which was what we were using some years ago. So this is very exciting news. And the whole idea is to meet the WHO target of, bringing down the statistics for cervical cancer by the year 2030. So for the prostate, prostate cancer is a very interesting cancer because, one, you have the Black man being at the top. When you talk about where it's common, it's not the Caucasian man, it's the Black man. So whether it's the Black man in Sub-Sahara in Africa, or the Black man in Britain, or the Black man in the US, the Black man, this is a disease that is very common amongst Black men. And unfortunately, because our men also are a bit reluctant to go for their screening or their health checks, it's detected a bit late when actually it's a very fairly straightforward cancer to treat as well. And so a man suddenly comes with the back pain. And that back pain, when they check, the PSA is high, they do the imaging, and you find that that back pain is because it has actually spread. It's now metastatic. And yet this cancer, once detected early, there are so many treatment modalities that means that this, the person is sorted and they can continue with their life. So the main things that we do for prostate cancer is the PSA, the prostate-specific antigen, which is a blood test and detects proteins from the prostate gland, and it has a range. So each lab has a different range, but by and large, you want the prostate test to be within that normal range. When it goes above the range, that is when you need to check for other things. It doesn't always mean it's a cancer. It could be a urine infection. It could be just a benign enlargement of the prostate that happens with men as they get older. But the important thing is you're monitoring and you find something, then you need to check it out. The other thing is the digital rectal examination, which is introducing a finger through the rectum to feel for the prostate, because the prostate has a characteristic size and feel. And for doctors who do this all the time, and for a patient who has a regular doctor who is used to examining them, when that prostate feels abnormal, your doctor knows. So even in the background of a normal PSA test, if your doctor examines your prostate and they don't like how it feels, they will send you for other tests as well. So for the colorectal cancer, the bowel cancer was not a cancer that was common in our environment, say 15, 20 years ago. But it started, the incidence is rising, and why? It has to do with our diet, the diet that we've adopted, food on the go, fast food, junk food, food that isn't healthy. And your bowel is where the food goes. That's where the digestion takes place. That's where food's absorbed. And that's where things are also exposed to any carcinogen that comes through all the things that we're eating. So initially, the colorectal cancer screening was at 50. But when these things started happening, especially amongst Black people, they changed it to 45. The UK still does it at 50, but most parts of the world, the US, we in Nigeria have started screening at 45. So the definitive test for cancer screening is what we call a colonoscopy. It's introducing a camera through the rectum again, the backside, and it just goes through the whole colon and rectum. And the whole idea is it's looking out for any abnormality, and that's what it is. And if you have a normal colonoscopy, you actually don't need to have a colonoscopy for another 10 years, except if you have a family history of bowel cancer, then you need to do it every 3 to 5 years. Or if you notice a change in your bowels, then you do it, earlier. And then if by the age of 72 to 75, you've had normal rectal screening, colonoscopy, then you don't need to continue. There's also a test that we use called the FIT, fecal immunochemical test. It's a stool test. It's not as sensitive as doing a colonoscopy. It only tells you if there's blood in the stool, but that can be done in between, within the 10 years, if you want to keep an eye on things. And so again, I'll mention that these are all available in country. We do this, and we have partners that do the colonoscopy, but we also test for the FIT at our facility. So in terms of the preventive aspects of cancer screening, and this is just ad hoc, I don't have a slide for this because to be honest, it's common sense. It's also the same prevention that we talk about when we, consider non-communicable diseases. It's interesting that most of the risk factors for most of these diseases are the same. When you talk about diabetes, when you talk about hypertension, when you talk about cancer, when you talk about kidney disease, it's, coming down to the same things that we all know and we all hear, but sometimes we don't, you know how it is, you, with all best intentions, you want to do this and that, but we end up not doing it. So, reducing your smoking I'm not even saying reducing, stopping smoking is one preventive, very important preventive aspect. Alcohol, minimal use. Most people don't know how to measure their alcohol intake. It's very important to know that in a week, you shouldn't actually exceed 12 units of alcohol. And how do you measure? Again, you measure in 2 units quota. So 2 units is a glass of wine. 2 units is a shot of spirit. 2 units is a can of beer. So that's how you actually measure the quantity. So if you're a wine drinker, for instance, and you already know that a glass of wine is 2 units, if you have 4 glasses of wine, then it's 8 units. And that is actually tantamount to a whole bottle of wine. 4 glasses of wine are in 1 bottle of wine. So that's the way you measure it. So that gives you a guide every week. How much alcohol am I actually taking? So they don't say, we don't say stop alcohol, but it has to be minimal. And you cannot binge drink. So you go through the week and you don't drink, and then you try to do your 12 units in 2 days. The liver will be traumatized by that. So I've talked about smoking, we've talked about alcohol, we'll talk about exercise, sedentary, sitting all the time, not moving around. And when I say that, it's not just the exercise where you're doing the aerobic, the cardio, the high impact, but it's also the question of moving, sitting up. Most of us are sitting at work. Most of us are sitting in traffic. So when you calculate how many hours you're actually moving around the house, moving around the office, that will give you an idea of how much activity you're taking in. The studies show that everyone should at least aim for 10,000 steps in a day. So whether it's 10,000 just going back and forth, or 10,000 inclusive of your, your skipping, your running, you're meant to be doing 10,000 steps. So that's one risk factor. Obesity has become a problem, being overweight. Most of us are over our BMI, waist circumference measurement, so exercise. The other thing is, of course, a healthy diet. I'm not going to go into the constituents of what a healthy diet is, but I always say to people, just imagine what we learned in primary school and secondary school. The basic rules are still the same. That round plate where you have carbohydrates, protein, vegetables, and all that, oils, is the same thing. Your carbs have to be less than your vegetable, but the diet we have now, the main meal is carbohydrates, and then you put a sprinkling of fiber, little salads and all that. So we need to reverse what we're eating. We need to be mindful of our junk eating on the go. Then the other things like sleep, stress reduction, these all add to preventive. And then in addition, I've already mentioned HPV, getting your vaccine. So vaccination for HPV and hepatitis. because the hepatitis virus is also one of the causes of liver cancer. So everybody should have hepatitis B vaccination because that's endemic in our environment, same as HPV. Okay, so I think that's it in a nutshell. I will stop here so that people can ask any questions or comments. Thank you very much.
Yes, you did awesome. You did awesome. Thank you very much, Dr. Oge, for that exhaustive. I think it's been you've gone through the big four for us in about 20-30 minutes, and that's awesome, which is very fantastic. I think that's something a fundamental to cancer awareness in Nigeria. So I would ask that you stand by so that we'll take Yewande Shehu now. So she speaks about asthma. Then after her, we take questions for both of you.
Okay, that's good.
All right. So Dr. Yewande
Okay,
Shehu,
I'll stop screen sharing, right?
Stop screen sharing, yes, ma'am.
Yeah, so she can share hers. Okay.
Yes, ma'am.
All right. Thank you.
Thank you, ma'am. Yewande Shehu, are you with us?
Hi, good evening. Yes, I am. So sorry, I don't have slides to share. I hope that's fine.
It's fine. It's fine. It's fine.
Okay.
You can move now. We are ready for you, Yewande.
Okay, thank you.
Yes.
Okay. So please, can you hear me well?
Yes, we can hear you.
Yeah.
And we can...
Okay, yeah, that's fine. So sorry, I'm like a bit under the weather. Yeah, the weather has been really terrible. So
we understand.
Just trying to. Yeah, thank you very much. So good evening, everyone.
Good evening.
My name is Yewande Folashade Shehu, and I'm the founder of Just Breathe Asthma Foundation. Now, Just Breathe Asthma Foundation is an idea I had for a very long time. Growing up as a child, I noticed that not much awareness was given to asthma. I am asthmatic, my younger brother is asthmatic, and my dad is asthmatic. So I've pretty much lived, like, in quotes, the asthmatic life. And so I saw that not much attention was given to asthma growing up and everything. And I said, okay, I kept on thinking of what I could do. I finished as a health prefect in my secondary school. And then it took COVID for me to actually realize that, okay, something had to be done because COVID was really tough for a lot of people who had asthma. So the plan was just to create a group chat where people could come and rant and just share how they felt with people who actually knew what it felt like to have asthma. Because a lot of people who had asthma had COVID, so, and a lot of people were not even sure. So like the community was like some people's solace, like they knew that people there understood what asthma was. And so today I'm just going to be talking a little about asthma and asthma management as a whole. So what is asthma? Asthma is a chronic long-term inflammatory condition of the airway that is characterized by the narrowing of the passage and tightening, making it difficult to breathe. Now, asthma affects all people, like there's no particular age. Asthma affects everybody, both the young, both the old, but most times it starts during childhood. And it is one of the most chronic diseases among children, meaning that a lot of children have it more compared to adults. An estimated 10 million Nigerians and 300 million people globally are said to have asthma. It is a non-communicable disease. That means it can't be spread or passed from one person to another. Contrary to what a lot of people think that, okay, asthma, if I use your spoon, if I use your cup, or if I use your inhaler and I don't have asthma, you have asthma. No, asthma is a non-communicable disease, and that means that you can't get it if you don't have it already, or you don't have the traits. Now, what causes asthma? The main direct cause of asthma is not exactly known, but there are certain factors that have been shown to make one predisposed to having asthma. Like myself now, like I got it because my dad has it, so it's hereditary, that's genetic factor. So asthma is more likely if there's a family history of asthma or any other allergic condition. And then 2, events in life which affect the developing of lungs, like low birth weight, prematurity, and exposure to tobacco and others at a very young age. And the 3rd one is obesity. fat tissues produce inflammatory substances that might affect the lungs, and number of studies have suggested that these substances could affect and trigger asthma. Now, what are the triggers for asthma? Like, a lot of asthmatics have different triggers, different people have different triggers. Note, there are common triggers that are associated with asthmatics, but everyone has their own peculiar triggers, and some of the common ones are dust, pets. You see people that are allergic to like fur or having cats as asthmatics, and you wonder, why do you have a cat if you know you're allergic to it? And they're like, oh, you like cats. So it has to go beyond liking it. You have to do what is best for you. You can't have a pet that triggers your asthma, because it doesn't like really make sense. You know this is what happens. So the main thing is to try and avoid your trigger. Others include smoke, grass, weather changes, exercise, cold, stress, and strong perfumes or strong smell, any strong smell. Now, how do asthma attacks happen? Now, many people just know that, okay, when somebody has asthma, the person cannot breathe, but there's a lot that goes on with the person when they're having an attack. So I'm just going to like share how an asthma attack happens. The airway of a person with asthma is very sensitive, particularly to certain triggers. Therefore, when an asthmatic is exposed to these triggers, things which cause their body responds by releasing antibodies that would bind or connect to certain cells to release chemicals, which are histamines and leukotrienes. Now, leukotrienes are one of the several substances which are released by mast cells during an asthma attack, and they are primarily responsible for bronchoconstriction. That's what will cause the inflammation. Now, these chemicals will also cause the airway passage to become smaller and to tighten it, and this will cause a lot of mucus to be produced. In the long run, if not managed, it will result in long-term wear and tear damage of the respiratory passage. Now, this just means that these triggers are what actually cause asthma, because when you're exposed to a trigger, your body like interprets it that, okay, you have done something you're not meant to do, or you've gone to a place where you're not meant to go, and that's the body's way of telling you that, oh, you've trespassed, more like in layman's term. Now, signs and symptoms of asthma. So a lot of people ask, oh, how do I know someone is having an attack, or how do I know I myself am about to have an attack? Some of the signs are shortness of breath, chest tightness. If you start feeling like your chest is tight, you can't breathe all of a sudden, cough. Now, for cough is a little bit tricky, because some people just have cough and it goes, but you know when a cough is linked to asthma: fast heart rate, chest pain, blue coloration of the lips, toes, or fingernails. That one is not so common. And wheezing sound, which is one of the most common ones. Now, how is asthma diagnosed? Like now, some people have asked, how do I know I have asthma? If my chest is paining me, do I have asthma? There are many ways of diagnosing asthma, but there are two common ways, which are the spirometry and the methacholine challenge test. Now, the spirometry is done with people who are already showing like symptoms of asthma. During this test, you breathe into a mouthpiece that is connected to a device called a spirometer. The spirometer measures the amount of air you're able to breathe in and out, and its rate of flow. You take a deep breath and then exhale forcefully. The values are then read and recorded. You would then be given a fast relief asthma medication to help your airway open or dilate. If the values improve greatly after this, then asthma is confirmed. This can only be done in patients showing symptoms. That means this spirometry can only be done if you're already showing the symptoms of asthma, like symptoms of having asthma. Then the second one is the methacholine challenge test. This is done in patients not showing symptoms as at the time when they just go. So probably they just feel like, okay, because of one or two things, they might have asthma. Methacholine is a drug that causes the airways to constrict. Asthma is confirmed if the values drop much lower than 20%, which is the normal. Now, how is asthma classified and treated? So you hear some people saying, oh, my asthma is not very serious. Oh, my asthma is serious. Oh, my asthma is everyday. So asthma can be classified based on severity and frequency, or based on cause. Now, for asthma based on severity and frequency, we have the intermittent asthma, which is less than twice a week. Nighttime symptoms are less than twice or 3 times a month. That means they don't have asthma attacks or the symptoms often. Mild asthma happens 2 times per week or 3 to 4 times in a month. Moderate asthma occurs 7 times a week during the day and then sometimes at night. And then severe asthma happens every day. morning and night. Now, the classification based on cause are exercise-induced asthma, allergic asthma, non-allergic asthma, occupational asthma, aspirin-induced asthma, or adult onset asthma. So you hear people saying, oh, I didn't have asthma as a child. Nobody in my family has asthma. Why do I have asthma? So these are some of the causes, some of the things that might have caused the asthma, probably exercise, occupation. When you work with around places that have chemical fumes, dust, or other things that irritates you. And then adult onset asthma, which is asthma that starts in adults. Now, treatments for asthma, there are like many treatments for asthma. Some are the medication, and which the major medication we know is the use of inhalers. Now, inhalers are divided into different types. We have the relievers, the controllers, the preventers, and then the combinations. The relievers are short-acting bronchodilators, and they are used for acute or sudden symptoms. They are used when the symptoms are present. An example is the regular Ventolin that we all know, the blue Ventolin, salbutamol. Then the controllers are used to manage asthma. They are long-lasting bronchodilators, and they are taken regularly. The preventers help to prevent and reduce inflammation or swelling and mucus production along the airways. While the combinations are, they combine both the controllers and the preventers. Example is Seretide. And then some other treatments for asthma include nebulizers, oral drugs, and injections. Now, first aid for asthma. So this is a very important part. What to do when someone is having an asthma attack. First things first, you have to loosen all the tight clothes on the person. Make sure the person is free. And then make sure the person is seated up, vested against something. That will help the person breathe a little bit easy. Call for help. Move away from triggers. If you are the one who is having the attack, move away from the trigger. If you are with someone who is having an attack, move the person away from the trigger, because you can't leave the person where there's a trigger and then expect the person to get better. The third thing, you have to sit up straight, like I said, and use your inhaler. Now, when an inhaler is not present, what do you do if an inhaler is not present? You practice breathing exercises, but you have to call for help too, because the inhaler is like the fastest thing to help someone who is having an attack. Remain calm. Now, as someone who is helping someone having an attack, the last thing the person wants to see or sense is fear. So someone cannot be trying to breathe and then you're like, wait, now, I'm coming. Wait, what should I do? That is already increasing the panic in the person. So you yourself have to remain very, very calm and then try to steady the person's breathing. Now, living with asthma management. So how do you manage asthma now? Do you have asthma? You found out that you have asthma. How do you manage asthma going out or in or staying inside? So some of the ways you can manage asthma when you're outside is you pay attention to the radio or television reports of whether, okay, the air is going to be like this today. This will help you to plan properly. Then plan your outdoor activities for when the air quality is best. So don't plan activities when you know it's maybe rainy season and you know that, oh, rain might meet you outside, or you might go to a place that is cold. If you have to leave your house, make sure you leave with like a sweater or a warm clothing. Like I, for example, now I don't go anywhere without my sweater. Whether or not the weather outside is hot, I don't know where I'm going to or what I'm going to meet. So it's better to be over-prepared than under-prepared. Then when there is burning, when you see smoke, avoid it. Don't just go and walk through it and say, oh, I can pass through it, nothing can happen. Avoid places where people smoke. Don't predispose yourself to places that you know that there's no way people won't smoke, like clubs. Going to clubs where you know they smoke all sorts of things, and you yourself don't smoke. I've seen a lot of asthmatics that smoke, and I'm like, okay, what's the plan? Like, what are you trying to do? And they're like, oh, they can't stop. So ask your healthcare provider on steps to help you quit if you're an asthmatic who smokes. Try to avoid heavy perfumes, hairspray, or anything that has strong smell. And then some disinfectants and cleaning agents, like they are strong. So you should know which one is strong enough to trigger your asthma and just like avoid it. Now, managing indoor trigger. If you're allergic to your pets, the best way to avoid like triggers is just to like do away with the pets. You can have a pet that doesn't trigger your asthma. Like I mentioned at the beginning, like you have a cat as a pet. I know you're allergic to fur. Fur doesn't make sense, because you know that every time this cat comes near you, you have an asthma attack or you have discomfort. So just do away with it. Ask, you can, for dusting and sweeping and other tasks in the house, you can let people who don't have asthma do it while you do the ones. So some people will be like, oh, they say I have to do it, I'm lazy. No, it's not a matter of laziness, just that they know you have asthma. Except if now the person doesn't know you have asthma, then that comes to another thing. Let someone know you have asthma. Let your family and friends know you have asthma. Let people you spend your time with, your office, people in your place of work. You are putting both yourself and your employer at risk if your employer doesn't know that you have asthma. I know that sometimes it's really difficult because a lot of employers don't want to employ people who have asthma based on their own preference, but it's better for them to know that you have asthma, and then they will know, okay, if it's a place that values you and values what you do, they would make provisions like, okay, maybe they'll give you a warmer part of the office, or when there are things that are involved, maybe spraying or painting, they would inform you in time. But you shouldn't ever risk your health because of somewhere. Imagine going to work in a construction company or where they produce chemicals as an asthmatic, and then nobody there knows you have asthma. What happens the day you have an attack? They will be confused, and then it might even make you to even lose the job in the long run. Then other management practices: maintain healthy body weight, breathing exercises, exercise indoors if you have to exercise. Make sure you keep your inhaler handy and others. Then how to use an inhaler, like the Ventolin inhaler, is very simple. But first things first, when you get your inhaler, or if you haven't used it for a long time, you have to like open it and then puff it out, just to let the air that is the air there to go. Then the next thing you do is you hold your inhaler upright and then take the cap off. Check that nothing is inside, maybe dust or anything. Shake the inhaler well. Sit upright or stand if you have to stand. You get. Then breathe out gently and slowly after you've used the inhaler. If you're not using a spacer, continue to breathe in slowly until your lungs feel full. Take the inhaler out of your mouth and with your lip closed, hold your breath for up to 10 seconds for as long as you can. Then breathe out gently away from your inhaler. If you've been prescribed a second puff, wait 30 seconds to a minute and shake the inhaler again. So you see a lot of people just using the inhaler, like the more you use it doesn't mean that how fast it will work. So there should be like a 30 seconds gap between the first time and then the second time. And then if you are having an attack and this doesn't work, then it's time for you to go to the hospital, because that means the inhaler at that point in time is not relieving you as it's meant to relieve you. So in conclusion, having asthma is not a death sentence. You can do whatever you want to do and become whatever you want to be, with or without asthma. Thank you.
Thank you very much, Yewande. What a session. Thank you so much. All right, do you have questions, 5-minute questions for Dr. Oge and Yewande? All right, Dr. Oge, I quickly have a question. How accessible are these cancer screening exercises that you mentioned earlier? Are they cheap? Are they affordable? Can we talk about them?
Thank you very much. They actually are. I remember we carried out an outreach in one of the markets in Lagos a few years ago. And, after talking, we had, we encouraged the women to carry out their tests. And the madams in the markets, came and said, so how much is this actually? And when we told them how much it was to come in for the breast examination, have their mammogram, they said, why did they think it was so much more expensive? You can't compare the cost of screening. It's almost like, okay, am I buying a Shebi Gele, or am I doing the test? Is that actually is affordable, much cheaper than even a full Ashebi? That's what I always say. So it's affordable. It's affordable considering these are also not tests you do regularly. So for instance, the pap smear, the cervical screening test, is every 3 years. If you think of the cost of what it actually is, over 3 years, it's barely there. However, just like every good country with good leadership,
ideally, some of these things should be virtually free or subsidized if it comes under the government's national cancer screening program. So for instance, the childhood immunizations, I don't think parents pay for that. You go into the primary care center and you get it. And even during COVID, the vaccines we were taking in the primary care centers were free. That ideally is what the screening should actually be. And we're hoping that at some point, Nigeria will get to the point where we don't even have to say, okay, I know it's affordable, but we want a situation where it's free. It becomes part of our health screening. So it is affordable. It is affordable.
Thank you, ma'am. Any other question for her? All right, I think that's it. Any question for you, Andy? Anybody?
Okay, I have a question for Dr. Oge. I know you mentioned the top 4. But one of the few cancers that I see springing up is lymphoma. How much information is being put out when it comes to lymphoma?
Yeah, so thank you very much, Toyin, for that question. As everything we have going on in Nigeria, data is one of the things we really lack. So, when you say lymphoma is becoming common, obviously it's not necessarily backed up with data, but I can understand why you might think that we might be having more lymphomas. And a lot of facilities in the cancer space are trying to promote, the whole education around lymphoma. The thing is, you can't necessarily screen for lymphomas in that sense. It's not like specific screening like you have for breast cancer, mammogram, or you have for cervical cancer. But what we always say to people, if you get to a certain age, please, by all means, every year, go into the doctors, run a few tests, do your full blood counts, your blood counts. The doctors will be able to see year after year, if there's any change. And then you yourself, when you notice anything, it's not a case of it's not my portion and all that. Let me, go, with all due respect, religion is fantastic, but it needs to go hand in hand with, going to see the doctors as well. Because what we're finding is sometimes people ignore things that they've noticed because, they are hoping it goes away. And by the time they come in to see the doctor, it's already advanced. So I would say in the case of lymphoma, just make sure you're going to see your doctor, you're doing all your checks, your blood tests and all that. And if you notice something that is unusual, then mention it. That is the benefit of registering with a family practice. I can't overemphasize that. Where we have a preventive culture rather than a reactive culture, you only go to the doctor when something is wrong. Go to the doctor when nothing is wrong.
Thank you very, very much. Thank you to our speakers. If there's any more questions. Yes.
Oh, sorry.
Go ahead.
I have a question for Dr. Oge. So how often do we check for the post-rates?
Oh, once a year.
Okay.
Once a year, at the most once every 2 years, but once a year. And that would start from the 40s as well. Sorry, I think I omitted that. Yeah, so
Okay.
You start from your 40s, from mid-40s. Some families where there's a prostate cancer history, they start earlier as well.
Thank you, ma'am.
Thank you.
This is KW.
I have another question for you, Dr. Oge. This might be off the cuff. What mentioned about mammogram, and I know the experience of going for a mammogram. I don't think I've had anybody who has
Sorry, I didn't hear that. Something is crackling.
Why? Yeah.
Sorry, what did you say?
Okay, yeah, you mentioned mammogram, and one of the things I've not had anybody say mammogram is pleasant. In fact, there's a lot of complaint about the pain you go through. And funny enough, I think this is why people just shy away of going to do the test. Are there ways that this can be altered or changed in the new technology of things?
Well, I don't know. Fortunately, I'm not at the end of the manufacturing of the machines. I do my mammogram, and to be honest, once it's done, it's done. It's not the sort of pain that lingers beyond the moment, if that makes any sense. And I actually personally don't, it's uncomfortable because, you know, the way the breasts have to be placed in between the two plates, but it's not unbearable. And I think I said that earlier. I think it's also a mindset thing about going for an investigation, you know. And I think once people can sort of say, you know, this is something that's got to be done, it does help. Even the cervical screening is not very comfortable. And I'm sure the men will also attest to the fact that the prostate examination is not uncomfortable, but these things are momentarily uncomfortable. So it's not like after your mammogram, then you're racked with pain for weeks on end. No, nothing like that. Once, by the time I'm changing, I'm putting on my clothes again, I don't actually feel the pain anymore. But people's pain thresholds are also different. And we hope that maybe at some point, you know, there will be more modernization of the machines as we go along.
All right. Thank you so much. If there's no other questions.
Hi, greetings. Hello.
Okay. Hello, KW. Yeah, go ahead.
Greetings, everyone. First of all, I just want to congratulate you all on taking the time to talk about NCDs, because around the world, that's a popular conversation. And congrats on Sammy on your 15th anniversary. So I guess to end, you're just a normalization, right? You're only 15 years old. That's how old you look now.
Yeah. No, not at all.
So you answered one question, Dr. Oge, which is about the frequency of prostate cancer, because we have a high incidence in our family, and one of our young males was advised to start testing at 30 or 35 because of, and you just said that if it's a high incidence in the family, then you should go ahead. Question though, should men check for breast cancer?
Very interesting, very, very interesting question. So men have breast cancer. I don't know if everyone is actually aware of it, that men can have breast cancer. Clearly, the incidence isn't as much as you have with the women. And unfortunately, because men don't exactly have breast tissue like women do, it's obvious you have a lump. Men's breast cancer is actually detected at a very advanced stage. So what we actually say is, if a man belongs to a family where there's a positive history of breast and ovarian cancer, it suggests that there might be a cancer syndrome in the family. The men in that family should actually examine the chest wall. So in their case, it's the chest wall, isn't it? But that's where the breast cancer, in quote, would start, where the, you know, the breast board is in their case. So yes, men, especially men with family history, genetic history of breast cancer in the family, should actually check their breasts. They can't obviously have a mammogram, because with a mammogram, you need breast tissue to check. But for the men, if you have such a history in your family, then please make sure, one, you tell your family physician, who can also help look at your chest wall every year.
And like the women who have cervical cancer, besides prostate cancer, do we concern about scrotal or penile cancer?
No, not necessarily. Prostate is very removed. It's a totally different cancer. Of course, you can have cancer in any part of the body, penile cancer, scrotal and all that, but the incidence of those are not as much as, prostate cancer. Yes. But having said that, we know that the HPV subtypes can cause not just cervical cancer, but can cause other types of cancers related to the whole genital area, just because of the different sexual practices that people adopt. So, you know, anal cancer can be caused by a HPV, oral cancer can be caused throat cancer. Anywhere there's exchange of fluids in sexual activity, you can actually have HPV there. So it's not just the the cervix because, you know, it's the man, the penetration, but actually anywhere that you have that sort of exchange. So whether it's oral, whether it's anal, and that's why doctors actually have to delve into sexual history when they have patients who present to them for the first time. When you do your normal clacking, you're discussing with the patient your medical history, your drug history, your allergy history. The sexual history is very, very important. You need to know what your patient is inclined to, because that can either be an increased risk for certain things or just it's a normal risk.
Thank you very much, Dr. Oge.
Thank
you. Thank you.
Sorry. Would I
Yeah, you have one more question.
I was just the doctor was speaking about sickle cell trait. Is there possible I can ask a question if he's still here?
Oh, he's left.
He has left.
Left, unfortunately. Yes, he had another. He's actually on call. I mean, working. So you know, time difference and all. Yeah. So he had some patients waiting for you. Thank
I'll
you.
email the
KW.
question to you.
Yes.
Thank you.
Can. I'll send it to him. Thank you. Thank you.
Bye.
Well, time has spent. Unfortunately, due to time, two speakers for the panel had previous engagement, so they had to leave. So we've had to cancel the panel discussion. My sincere apologies. It took quite a bit of time. But that's the thing with medical. We're interested in knowing a lot of stuff, and it's important that we ask questions and we get the answers as much as possible. So I want to thank everybody. We thank first of all our first speaker, Dr. Gladson Aiwele, and Dr. Oge Ilegbune, and of course Dr. Yewande Shehu. I hope I pronounced that thing. Thank you so much for education about asthma. And you know, the thing about, you're correct about that animal thing. Some people love pets, but they know that they get affected by that too. And asthma is very important in awareness, because I had a cousin who unfortunately passed on. And one of the challenges we see in asthma is that night, I said they have some things like common like sickle cell, where you have those episodes at funny hours of the night, and you're now running to look for a hospital. But we hope in due course our healthcare system will improve and to be able to accommodate more of these challenges. I'd like to thank also our guests, and my sincere apologies to them, Sharon and Halima, for not being able to hold the panel discourse. I know that we'll be calling upon you one more time in the near future. I want to thank everybody. I mean, I'm so overwhelmed with the amount of people that even came. I'm even thanking you for even staying up to this time, to be able to take time out of your schedule to stay on this late. I'll remind you that tomorrow is our final day where we have the physical events, and I hope we'll be seeing you. It's going to be quite interesting as we delve into health in different aspects of life, from the mental health to the nutrition and to the arts, and finally to the neurology of sickle cell, neurology and sickle cell, with our keynote speaker, Dr. Mustafa Danisi. I hope to see you 9 a.m. tomorrow at Afagabala Hall, University of Lagos. Thank you, everybody. God bless you. And have a good night. Thank you so much. Thank you, everybody. Oh,
thank you, Toyin.
Thank you. Can for a quickie, if you can put on before we leave, please, if you can possibly put on your, let's take a quickie of a picture.
Yes.